My client's doing that, and I see that their knee is caving in. What could you do to strength test, address, and condition what you believe to be a not so good movement pattern? What would you do with your hand driver? Well, let's practice this. You guys ready? We're all going to do this on cue. Your right foot's going to go forward. You're going to do exactly what you just did to prove a point. Take your right and left hand, go right foot anterior, reach way out. Shortest distance between A and B is a straight line. Now, the next one, try to synchronize this. Take both hands, same exact lunge, same exact side, but rotate to your right. Use a hand driver. So go to your right, okay, and then come back. So to your right, so you're going to the leg you landed on. Now what you're going to do is you're going to rotate to your left. Same exact foot, same exact lunge. Ready? Go for it. Okay, true or false? Some of you didn't do it. I'll do it one more time. Some of you are going opposite. It's probably because me, I'm a terrible instructor up here facing you. Listen carefully. 3 of them. 2 hands, anterior. Everybody do that. Anterior. So you're tracking anterior. Everything should stay straight because that's the driver. Remember, the driver controls it. You're in a car right now. But if the driver says go left and go right, the reaction changes. The stresses change in the car. Okay? So now what you're going to do is take your hands and you're going to rotate to your right because your right foot is forward. Ready? Go. To your right. Good job. Now you're going to go to your left with the hands. True or false? When you went to your left, your knee came in. So if I put a video camera on you, either you're all wrong or all right. Silly rule. Keep the knees over this and that toe, isn't it? Might be right for some of the people some of the time based on the pathology. So what caused your hands or your knee to come in when your hands drove like that? It's called a displacement in your body knowing it has to keep the center within the changing base of support. So don't get confused if the knee comes in. It's the sequence at which it comes in. It's the speed at which it comes in. It's the timing at which it comes in. So now let's go back to our case scenario. The right foot goes forward and this client just keeps doing that. That just doesn't look good. That's a tomato. That's a tomato if I do this. Right? That's a Super Bowl. So how, as movement practitioners, can we help to facilitate Super Bowl on a tomato? You guys ready? In straight out. Get them out as far as you possibly can. As your right foot lands, rotate to your right. Rotate it. When you have that client that comes in and that knee's caving in, I promise you, with a little bit of creativity, you'll get them to straighten that baby out. Okay, that doesn't make the other one bad to do. You're always going to be weaker going that way. Anybody know why? If you take your finger and you stick it in your connective tissue back here, it takes a long time to get to your femur. Okay, everybody do this. Close your eyes and touch your butt for me. Close your eyes, touch your butt. Okay? Now immediately, your eyes are closed, touch it, touch it, touch it, touch it, go to the front of your body. Which one's bigger? There's always one dude that says the front. Which one's bigger? The back. You don't have a butt in front, do you? Okay? Because of gravity. That's why. So when you drive your hands to the left and your right foot's forward, you don't load as much of the tissue. It's still loaded, but not as much. So if you want your knee, which is a space stuck in the middle, got nowhere to go and nowhere to hide, to be more efficient with the rest of the team members, guess what you have to do? You have to load it the right way. You see, so if you take your right foot and you go anterior and you rotate, it loads this tissue. That's why your knee starts to migrate slightly. Slightly. When you go this way, you're still loading the tissue, but not as much. It's inherently weaker. You'll feel you're less Super Bowl-like. So that's based on what you properly said. When you start adding hand drivers, it drives the reaction differently. Here's the cool thing. There's not a book out there that you need to understand this with. You go into your gym, and the best way to do it is nude in the mirrors. Just kidding. Go into your gym and use your body as a lab. Use your body as a lab. Okay, because every time you move the body and displace it, it creates reactions. The truth is in the reaction. If it's not efficient, it feels like a tomato, then you have to work on why. Okay, and that's why people hire us. Okay? Now, so we did some squats, we did some lunges, but let's tone it down a notch. Let's work with somebody that's 65. Everybody ready? Okay, and you can do this, you can do it prone, you can do it supine. So this isn't just standing. Okay, all the positions in the world are really standing, seated, kneeling, supine, prone, and sideline. Which brings up a point. You guys, would you mind doing this? I know this is kind of a little bit of a health hazard because the floor is super clean and it's a little rough. But get on your knees if you want. If you don't want to, I understand, but just, you don't have to do the exercises. I'm going to do this really quick because this is something that's so healthy for the hips and rarely people do. Every single lunge you guys just did can start from here. Have you ever thought about that? If you want to try it, go ahead and try it. If you don't, I understand. Usually I do it with the RX pads. And definitely, you have to have a cushy pad because of the inherent compression on your knees. Some of you may not have knees that like this. But watch this closely. If I take my right foot down and I drive the anterior, you're now creating deeper hip excursion because the femur on my left lags behind the drive because of the contact of the left into the floor. So I'm using gravity, reaction, mass, and momentum as my friend to try to assess or address, condition some of the deeper hip tissues or more localized versions. So now take your left and go forward, like that. Now you throw right foot, right lateral, left foot, left lateral. Right foot, right rotational, left foot, left rotational. And most importantly, with happy, healthy hips, you're going to want to do transitions. So you guys ready for this one? Right foot anterior lunge to stand. And then go back down to kneel. Left foot anterior to stand. And then back down. Right foot right lateral to stand. It's usually tougher for people. Then back down. Left foot left lateral to stand. Back down. Right foot right rotational. Back down. Left foot left rotational. Back down. And if we can't do that, we wonder why we're down here and we blow our back out. Okay, or we change a diaper, we go to pick something up. Okay, these water bottles will get delivered to our house, they're glass bottles, and it's like, man, you gotta get down there and pick it up. If I'm a tomato, guess what? It's not happening. So then I wear the plastic ones. I get all these estrogenic properties that aren't healthy for me. I got some nutritionists in our room. Okay. How about tone it down? Let's do this. Let's get down, kneeling. Cushy pad, make believe. Hand reach. Right hand reaches anterior as far as possible. As far as possible. As far as possible, like that. Now, you got two choices. You can do this, right? I call it micro whiplashing. Or you can be efficient with it and say, Mary, what I'd like you to do is take your right hand, reach anterior, but take your left elbow and go posterior for me. So what does that create? Left hip internal rotation and right external rotation, doesn't it? We're going to call it a soft rotation, but let me tell you something. You're 65 years of age, this is cool. Okay, again, we can be on an RX pad, we can do it seated too. You can be seated on a Dynadisc, for those of you that are therapists. And what you do is you drive the body, so you mind yourself. You're seated on a Dynadisc, so you got a nice fluid type environment. Now when you reach the person's hand, what you do as a therapist, as you perfectly said, is, hey, maybe you can put your hands on her pelvis, and you get her now or him to move the pelvic girdle over the femoral heads, which are chilling because you're seated. Okay, but it's creating a pump-like action. That's all you have to remember. Just like a breath cycle, just like a heartbeat. It's a compression-tension phenomenon. That's what we need to get in to our hips. We got to pump these fluids. If you have a pond in your backyard without a stream in or out, it looks good for about a day. And then it becomes stagnant. This is what happens to these fluids, literally. And then everything just gunks down. Okay, so toning it down, we can simply use reaches in all different positions. But what you're looking for as a movement practitioner is how is it affecting the hip complex. If you just go around doing this, like this, that's micro whiplashing. It's not creating. Now, it may be the speed, the driver's too fast because the body perceives instability. What does it do? It tightens up. If you're walking and all of a sudden you hit black ice, you don't go. What you do is you seize up. And that's what you see in the older population. They're afraid to move. So we have to select movements using our variable list that are A's on the report card. Okay, so here's another example. Let's everybody stand up. We're going to do what we call local excursions. This gets into really honing in on unilateral ability. What I'm going to have you do first is a toe touch. So right down, toe touch left. If you lift your left foot up, we're going to call that 10 on the volume knob. If you toe touch, we're going to call it a 9. Watch carefully. 8, 7, 6, 5, 4, 3, 2, 1. That's your assessment. You see people all the time. The body always figures out where it's stronger, where it can be more efficient. That's its design. The organism is designed that way. So watch people, because as they start hitting their functional threshold, they start dumping. So the volume knob works really well. So this is a 10. This is a 9. I want you on 9. Okay? Hands on pelvis, soft bend and knee. Simply ask them. This is more local, so that model I shared with you, we just did a bunch of global stuff. We did lunging, squatting, reaching, talked a little bit about walking. But now what we have is local. We're going to be isolated to the pelvic area, or the hip complex. Hands on pelvis, just tip it forward for me. Tip it forward and back. That's as simple as that, right? Tip it forward 3 times and back. Go a little farther if you can. Try not to bend the knee. You're really trying to feel when you do this. And then your hands on a person. Watch. Can they do this? I don't need the spine to flex. We can do that another time. I want to see if that pelvis goes forward. Period. You'll find a lot of people have trouble with that. Their body senses, no, too far out, get back home. And they just start to tighten up. Just like walking on ice. You guys know it is not healthy to hold on tight. That creates injury. We didn't teach a child how to ride a bike that way. Sweet, look at this big hill. Pretty scary, huh? Hold the handlebars as tight as possible. Suck your gut and squeeze your glutes. Give it the best. Where I live, you get arrested for that. Right? You gotta be relaxed. And that's the key with this, okay? So your toe touch, right? Now what you're gonna do is you're gonna AD duct. So what you do, toe touch, AD duct, and then return. AD duct, return. AB duct, just lift up. If you can lift your leg, go for it. Lift your leg up like that. Awesome. So AD. 2 questions I have for you. Number 1, do you have the range? Number 2, can you come home? Number 1, do you have the range? Number 2, can you elastically recoil back home like you guys threw a ball to me? Super ball back home? Or is it a tomato? A lot of people have the range, but they're a tomato. They lose the energy. Now what you're going to do for internal rotation, and you can do it at varying depths. Always remember that. There's so many variables to this. I'm just giving you the Our Dr. Seuss version. So you take your left side, little by little, little by little, nice and slow. Now mind you, the pelvis is moving faster than the femur, so the femur bone, I repeat, bone externally rotates. But because the pelvis goes farther and faster, it is net internal rotation of the joint, which is a space. If you videotape it out and you remind me a few times, it'll make a lot of sense. Okay? But remember, 2 bones move in the same plane at the same speed. The net motion at the space is 0. You have to have a differential. In the textbooks, they taught us still bone on moving bone. In reality, they both move. They just have to have a differential in order to facilitate stability. So that's the internal rotation. How about the external rotation? So you're going to tip out this way. It's a great assessment for people. Because of course you guys, I know you're smart enough, you're going, what about the foot? Right? You're linking it, I hope. Right? So if we did a foot course right now, we'd be doing the same excursion, but we put a little emphasis on the foot complex. So let's do that. I'll face you guys. Ready? Toe touch on the left. Right side's down. Toe touch around to test internal rotation. This should be concomitant with supination. Your foot should come up. If your foot's really flat and it's hunkering down, your toes are grabbing on for dear life, it gives me a good indication of what's going on. Now when you're out on the basketball court, you're out with your kids at the beach and you whip around like that, that's why these things happen. It's called tearing and injury, disruption of unity. So we're able to hone in locally and figure out what's going on with the person. It's very powerful. Now I'll do it in external rotations. You ready? Right side's down. Toe touch. Open, open, open. Valgusing is normal as long as it's synergistic with the chain. So if I have a real high arch, I'm not going to do these exercises with you. If it's a structurally rigid foot, I have no business in your training and conditioning program lunging you like this. I guarantee they either compensate really well or eventually going to tear the knee or it's going to start to bark right here. And then everybody blames the meniscus. Everybody blames the medial hamstring group. Everybody blames the groin or they get the sports hernia. You guys, these are victims. You can easily assess this stuff on people. Now, if you put your hands down there and maybe facilitate internal rotation of the tibia to get the foot to collapse a little,